When we think about the absolute highest stakes moments in nursing, I really think our brains have been completely conditioned by Hollywood. We immediately jump to the cinematic stuff,
Oh, absolutely. The alarms blaring, the running down the
like the
halls.
code blue, someone doing chest compressions, or, a nurse calculating a complex medication dosage in mere seconds, or threading an IV into a tiny vein in the back of a moving ambulance.
Naturally, because that's the drama, right? That's the highly technical side that looks fantastic on camera. It's tangible, it's visible, and I mean, it's obviously critical to patient survival.
It is, exactly. But today, for all of you listening, we're jumping into a deep dive on a stack of research that argues there is a skill that is just as critical, and maybe even more so for long-term patient outcomes, that so often gets dismissed as just soft skills or just being nice.
Which is such a dangerous
It
misconception.
really is. We are talking about communication.
Mhm.
And not just, chatting about the weather or complaining about the cafeteria food. We're talking about communication as a precise, scientific, therapeutic tool.
It really is the bedrock foundation of safety in healthcare. I mean, think about it. If you can't communicate effectively, your assessment is immediately flawed because you missed the data. And if your assessment is flawed,
Then your whole care plan is wrong.
exactly, it doesn't matter how flawless your IV skills are if you're treating the completely wrong problem because you missed a subtle cue in the conversation. Communication is the literal bridge between your vast medical knowledge and the actual human being lying in that bed.
So, consider this our deep dive into the art and science of talking.
Yeah.
And to keep things grounded, I want to approach this specifically from the angle of the preceptor and the student. So I'll play the role of the eager, maybe slightly naive student nurse.
Okay.
And you are the seasoned preceptor guiding me through the absolute minefield of what to say and, honestly, what not to say.
I love that setup because, quite honestly, students often struggle the absolute most with this. They know the anatomy, they've memorized the pharmacology backward and forward, but they just freeze when a patient starts crying or gets unexpectedly angry. So let's unpack the actual architecture of how we connect.
Okay, let's start with the basics then. The source material outlines different levels of communication. And the very first one listed isn't even about talking to another person. It's intrapersonal communication.
Right. Intra meaning inside. This is your internal self-talk.
So literally just the voice inside my head.
Exactly. And the reason the research emphasizes this right out of the gate is that your internal dialogue completely dictates your external performance. If you were walking into a patient's room thinking, I am terrified of this procedure.
Or like, oh man, this patient's gonna be so difficult.
Yes. That internal narrative leaks out. It changes your vibe before you even open your mouth. It changes your posture, your tone, your willingness to actually listen. If your internal self-talk is negative, you are essentially disengaging before you even walk through the door.
So you have to fix your own head before you try to fix the patient.
Precisely. The goal is to transform that interpersonal dialogue into a mental rehearsal of confidence. You have to coach yourself first.
That makes total sense. And then obviously we have interpersonal, which is the one-on-one, and small group for team dynamics. The sources also mention electronic communication, which feels very modern.
It's becoming huge, honestly. The key takeaway there is maintaining professionalism in the digital space, avoiding all CCAP-PS in your charting because it literally looks like you're screaming at the next nurse on shift, and keeping internet slang out of health portals. But the real meat of the theory here, the core of it, is the circular transactional model.
Okay, that sounds like a horrible geometry problem. Why do we need a complex model just for talking?
I know it sounds dense, but it's crucial because most people operate on a linear model. They think, I shoot an arrow of information at you like, take this pill and you catch it. Done. Conversation over.
Which is definitely not how real life works at all.
Yeah. Not even close. The circular transactional model recognizes that communication is a continuous flowing loop. You have the referent, which is the actual motivation to speak, like why are we even talking right now? Then the sender encodes a message and sends it through a channel, so that could be spoken words, a written note, or even a touch.
And the receiver decodes it.
Right. But the loop isn't closed until there is feedback. The receiver responds, confirming whether the message actually landed correctly. And here is the real insight for you listening. All of this is floating inside two giant bubbles called environment and interpersonal variables.
Interpersonal variables. So that's like the baggage we bring to the conversation.
Precisely. It's your biases, your education level, your developmental stage, and importantly, physical pain. So if I'm the nurse explaining discharge instructions, I'm the sender, and you are the patient, the receiver. But let's say you were sitting there in level 8 pain, which is a massive interpersonal variable, and the TV is blasting the news in the background, which is the environment.
Oh, that message is just dead on arrival.
Completely dead. The variable of pain completely overrides the cognitive processing of information. So as a nurse, you aren't just responsible for the words coming out of your mouth. You have to engineer the environment first. You turn off the TV, you treat the pain, then you talk. If you don't account for the variables, you're just making meaningless noise.
That leads us pretty seamlessly into the whole distinction between verbal and nonverbal communication.
Mm.
The data here in the sources is actually pretty stark. The vast majority of communication isn't the words at all.
Not at all. It's the posture, the gait, the microfacial expressions, and there is a crucial concept here called congruence.
Congruence. So, like matching.
Yes. Does your face match your words? If you walk into a room, check your watch, cross your arms, and say in a flat monotone, "I'm so happy to be your nurse today," what is the patient going to believe?
They're going to believe you'd rather be literally anywhere else on the planet.
Exactly. The body never lies. If there is a mismatch, the patient will always believe the nonverbal cue over the verbal one. You have to constantly read the room and ensure your body language signals safety and that you have time for them, even if you're internally rushing.
There's also a note here about denotative versus connotative meaning in verbal communication. This feels a bit like a high school English class lesson, but why does it matter so much in a hospital?
Because words carry immense emotional weight. Denotative is the literal dictionary definition. Connotative is the emotional meaning attached to it. Take the word code. To a nurse, that means a very specific, orderly set of clinical protocols. To a family member sitting in the room, hearing someone yell code might just sound like terrifying, life-ending chaos.
Oh, or the example in the notes about telling a little kid you're going to give him a stick.
Right. You mean a small needle prick for a blood draw. They imagine a giant branch from a tree or a weapon. You have to strive for absolute clarity and brevity. Say exactly what you mean in as few words as possible to avoid those connotative traps.
Okay, so we've got the mechanics down. Now let's look at the actual timeline. The source material talks about the nurse-patient relationship as having a very specific life cycle. It's not just a random hangout. It has a clear beginning, middle, and end.
It does. And unlike a regular social friendship, which might go on indefinitely and is a mutual two-way street, a therapeutic relationship is time-limited and highly goal-oriented. It starts with the pre-interaction phase.
This one actually surprised me because it happens before you even lay eyes on the patient.
This is your detective work. You're reviewing the chart, getting the handoff report from the previous shift, looking at the fresh labs. You're anticipating what they might need, but, and this is huge, you're also checking your own bias. If you see the patient has a history of severe drug abuse or a highly stigmatized infectious disease, you have to acknowledge your own internal feelings about that right then so you don't project them when you walk in.
Fix the interpersonal before the interpersonal.
Exactly.
Then comes the orientation phase, the big meet and greet.
This is where you establish trust. And here's a pro tip from the literature that I absolutely swear by. Sit down.
Really, just sitting.
It sounds almost too simple, but it's a massive power move in a benevolent way. If you stand over a patient while they are lying flat in bed, you are physically asserting dominance and signaling that you have one foot out the door. Pulling up a chair and sitting down puts you at eye level. It explicitly says, "I have time for you," even if you literally only have 5 minutes before your next med pass.
The sources also warn that in this phase, the patient will test the nurse.
That sounds a bit adversarial to me.
It's not malicious at all. It's purely anxiety. They are in a highly vulnerable state. They want to know, is the person competent? Will they keep me alive? So they might ask you very specific, detailed questions about their meds, or they'll watch like a hawk how you prime and set up their IV. They are just testing to see if they are safe in your hands.
So the advice for the student nurse is just don't get defensive. Correct. Do not take it personally. Just calmly demonstrate your competence. Once you pass that little test, you move to the working phase. This is the real meat of the relationship. This is collaborating to solve problems, encouraging them to express feelings, and doing the actual heavy lifting of nursing.
And finally, the termination phase, the breakup.
The professional breakup, yes. The key strategy here is to remind the patient that termination is coming well before it actually happens. You don't just wave goodbye as you're grabbing your bag at the end of the shift.
Right, like my shift ends in 10 seconds. Good luck with the next guy.
That creates immediate abandonment anxiety. You prepare them. You say something like, "I'm here until 7 p.m., so we have about an hour left together. Let's review what we accomplished today." It allows for reminiscing and ensures a really smooth, safe transition to the incoming nurse.
I really love that. It's all about providing proper closure. Now, let's get into the toolbox. This is the part of the deep dive where I want to get really, really specific. We have therapeutic techniques, which are the do's, and non-therapeutic techniques, the don'ts.
Let's start with the do's. The absolute foundation of everything is active listening.
And there's a mnemonic for this in the research, right? The surety model.
Yes, surety. It's a great mental framework to check your physical presence in the room. S stands for sit at an angle. U is uncross your legs and arms so you look open. R is for relax. E is eye contact. T is touch, if it's culturally and personally appropriate. And Y is your intuition. It basically physically forces your body to be open and receptive.
One of the therapeutic techniques listed here actually seems totally counterintuitive to me. Silence. As a natural talker, silence feels agonizingly awkward. I just want to fill the gap.
That is a very, very common impulse, especially for students. We hate dead air. But in a clinical setting, silence is a profoundly powerful therapeutic tool. It gives the patient necessary time to organize their thoughts.
Can you give me a real-world example of that?
Sure. Say you ask a patient, how are you coping with this new cancer diagnosis? And they just go quiet looking down at their hands. Your human instinct might be to jump in and say, it's a lot, isn't it? You must be so scared.
Which honestly sounds nice and empathetic.
It sounds nice, but you just completely interrupted their internal processing. They were actively searching for the right words to describe a very complex, heavy feeling, and you just shoved your own words into their mouth. You have to get comfortable with the quiet. Let them break the silence when they are ready.
Wow, that is going to be incredibly hard to practice. What about paraphrasing?
Paraphrasing is your built-in safety check. It's simply repeating the patient's core message back to them in your own words. So what I'm hearing is that you're worried you won't be able to handle the complex wound care once you get home. It confirms you actually understood the message, and it deeply validates to them that they were truly heard.
That brings us perfectly to the don'ts, because the sources are very clear that some things we say socially every single day are incredibly toxic clinically, and the big one is false reassurance.
This is a huge, huge barrier. Phrases like, don't worry, everything will be okay, or you're in great hands, you'll be fine.
I feel like people just say that to be comforting, though.
We say it because we are deeply uncomfortable with their pain and fear. We want to magically fix the negative emotion. But if a patient is facing a highly risky open-heart surgery, everything might not be okay. By saying it'll be fine, you are essentially telling them that their perfectly valid fears are wrong and that you are not a safe person to talk to about the scary stuff. You've completely shut down the conversation.
Oof, that really hits home. Another one on the naughty list is asking why questions. Like, why are you so anxious? That sounds innocent enough to me.
It sounds innocent, but the word why inherently demands a justification. It automatically puts people on the defensive. It sounds exactly like a parent catching a toddler doing something wrong. Why didn't you take your blood pressure meds?
Yeah, hearing it out loud, I can completely see how that feels accusatory.
Exactly. So instead of why, try making a gentle observation. I notice you seem a bit restless this morning. Can you tell me what's on your mind? It invites collaboration rather than demanding an explanation.
I see the difference. It's huge. And then there's the whole battle of sympathy versus empathy.
Yeah.
In the real world, we use these words completely interchangeably, but in nursing, they're functionally different.
Very different. Sympathy is, oh, I feel so sorry for you. It's pity. It focuses entirely on your feelings about their tragic situation. It blurs the professional lines. Empathy, on the other hand, is, I understand this is incredibly hard for you. It maintains a strong professional boundary while deeply acknowledging their human experience.
So if I'm understanding this, empathy is standing next to them down in the dark hole, but sympathy is actively jumping into the hole with them.
That's a great analogy. And if you jump in the hole with them, you lose your leverage. You can't help pull them out. You absolutely need to keep your professional footing.
Which leads right into the professionalism checklist. No calling patients honey or sweetie.
Absolutely not. Terms of endearment are patronizing and condescending, even if you genuinely mean well. Use last names for adults until they explicitly invite you to do otherwise. And never, ever refer to a human being by their room number or disease. Calling someone the gallbladder in 204 is totally dehumanizing. That is Mr. Jones, and he happens to be having gallbladder surgery.
Got it. Now let's talk about the heavy-duty tools, the standardized protocols. The sources highlight two acronyms, AIT and ISBAR. These sound like secure military communication codes.
They essentially are. They're highly structured algorithms designed to reduce errors and standardize safety across the board. AIDIT is mostly focused on direct patient interaction.
Break that one down for me.
A is acknowledge, greet them, make them feel seen and safe. I is introduce, tell them who you are, and build trust. D is duration. And this is the one that almost everyone forgets.
Telling them exactly how long something is going to take.
Yes, because anxiety thrives in the unknown. If you say, I'll be back with your pain meds, that could mean 5 minutes or it could mean an hour. If you say, I have to go pull these meds from the pharmacy, it will take me about 15 minutes. You decrease their anxiety instantly because you set a clear, measurable expectation. E is explanation. Tell them exactly why we are doing things. And T is just simply, thank you.
Simple, but clearly effective. Now, what about ISBAR? This one seems much more geared toward nurse-to-doctor or nurse-to-nurse communication.
ISBR is the gold standard blueprint for clinical handoffs and urgent reporting. It completely prevents you from rambling when time is critical. I is introduction. Who are you and where are you calling from? S is situation. What is the urgent problem right this second? B is background. Give the context, their admission diagnosis, relevant meds. A is assessment. What do you, the nurse, think is actually going on?
And R is recommendation. And the source actually notes that this is where students and new grads often crash and burn.
Because it requires a lot of clinical assertiveness. It is very hard for a brand new 22-year-old nurse to call an attending physician at 3 a.m. and say, I recommend you come see this patient right now, or I need an order for a stat chest x-ray.
Feels incredibly presumptuous.
It feels that way, absolutely, but it's essential for safety. You are the eyes and ears at the bedside. If you just rattle off a list of symptoms without a recommendation, you're forcing the provider to guess what you need from them. You have to boldly own your assessment.
Okay, so we've covered the standard, typical patient interaction. But nursing constantly throws you into highly complex, specialized scenarios. The sources spend a lot of time on adapting communication for specific needs, like sensory impairments and unresponsive patients. Let's start with the visually impaired.
The primary key here is to constantly vocalize what is usually just visual. You must identify yourself clearly every single time you enter the room, and crucially, you must tell them when you are leaving.
Right, otherwise they're just talking out loud to an empty room.
Exactly, which is incredibly disorienting. And watch the physical environment. Indirect lighting is much better to avoid harsh glare. For feeding them meals, you should use the clock method.
The clock method, how does that work?
You orient their plate like a clock face. You say, your chicken is at 6 o'clock, your green beans are at 3 o'clock. It gives them the dignity and autonomy to feed themselves. And obviously, no gestures. Pointing to the bathroom down the hall does absolutely nothing if they can't see your hand.
Right. Then we have the hearing impaired. Honestly, my first instinct would just be to shout so they can hear me.
Please don't do that. Shouting naturally raises the pitch and frequency of your voice, and high-frequency sounds are almost always the very first to go with age-related hearing loss. You actually want to speak slowly, use a normal volume, but actively lower your pitch if you can, and ensure the room is well lit so they can clearly see your face for lip reading.
And the notes mention checking for their equipment first.
Always the first step. Do they actually have their hearing aids in? Are the batteries dead? Do not start doing a complex neurological assessment on a quote-unquote confused patient who simply left their hearing aids on the nightstand.
That is such a great catch. What about non-English speaking patients? The rule here seems pretty strict. No family members as interpreters.
Correct. It puts family members in a terrible, highly stressful position, and they may intentionally filter bad news or completely misunderstand complex medical terminology. You must use a hospital-approved professional interpreter. And here's a major clinical tip. When you are using an interpreter, look directly at the patient, not the interpreter. Keep that human connection with the person you are actually treating.
Got it. Finally, let's talk about the unresponsive patient. The patient in a deep coma or who is heavily sedated on a ventilator. This one always feels really eerie to new students.
It can be unsettling, but the golden rule in all the literature is extremely clear on this. Speak as though the patient can hear every single word.
Every word.
Everything. Call them by their name. Use gentle touch.
Yeah.
Explain every single procedure before you touch them. Say, Mr. Smith, I'm going to wipe your face with a cool cloth right now. Even if they are completely paralyzed and cannot respond, we have significant scientific evidence that hearing is very often the absolute last sense to go.
And the source has a very specific stark warning here. It says, avoid talking about the patient in their presence.
This is a massive dignity and ethics issue. Do not ever stand over an unresponsive patient and casually discuss their grim prognosis or their family drama or where you're ordering takeout for lunch as if they're just a piece of furniture in the room.
It's just entirely dehumanizing.
It truly is. And if they can hear you, and clinically, you have to assume they can imagine, the sheer terror of lying there, trapped in your own body, hearing the medical team discuss your failing organs while completely ignoring your actual presence. You need to actively provide orientation. Tell them where they are, what day it is, and reassure them that they are safe.
That is incredibly powerful. It really drives home the whole point. The communication isn't just transmitting raw data. It's an active care.
It is the primary vehicle for care. We walk through the circular transactional model, the 4 phases of the relationship, the entire toolkit of therapeutic responses, and the standardized safety tools like AIDIT and EaseBar. But all of it, every single model, every acronym, serves one core purpose: to promote the patient's growth, safety, and health outcomes.
So let's wrap this up for you listening. We started by stating that talking is a high-stakes clinical skill. I really think we've proven that today. It requires deep preparation, strategy, and constant real-time adjustment to the environment and the specific person in front of you.
Absolutely. From the very moment you review that chart in the pre-interaction phase, all the way to the final goodbye and termination, your words, and importantly, your chosen silence, are active therapeutic interventions.
Here's a final thought to leave you with, something that really stuck with me from that last section on unresponsive patients.
Don't.
If the clinical guidance is to speak to an unresponsive patient as if they can hear absolutely everything, because hearing is the very last sense to fade, it makes you wonder. For everyone listening, how many conversations have happened over a hospital bed about lunch plans, complaining about long shifts, or bluntly discussing a terrible prognosis that the patient heard every single word of?
That is a deeply sobering thought.
It's a challenge to all of us.
Yeah.
Treat every single interaction, whether verbal or silent, as if it matters immensely, because it really, really does.
That is the ultimate standard of care.
Thanks for taking this deep dive with us. We'll see you on the next shift.